The opportunity to be part of the symposium, and while they're loading up my talk, certainly it's encouraging the more recent improvements from the SHFG trial with ibabradine and certainly Entresto LCZ 696. Hopefully with advances in medical therapy that will alter the natural progression to where there'll be really less morbidity related to heart failure in terms of reduction in readmissions. Having said that, much like the paradigm in the setting of shock, I think devices continue to evolve. And what I'd like to put forth is an update with focus in on the CardioMEMS device that has matured the most in this field and was more recently, over the last several months, approved by the FDA for the management of chronic smoldering heart failure. So specifically, my aim is to just put forth the physiologic premise that underlies the use of devices in terms of detection to guide management, summarize the available data, largely the CHAMPION trial, which we had the privilege of being part of several years back. I'll describe the device implantation in the cath lab in just a few brief cases to illustrate these concepts. So as mentioned, certainly heart failure is a real problem. And in the United States, with the Affordable Care Act back in 2010, we as an institution across our sister hospitals, which there are now 7, there is a potential penalty if we exceed a certain readmission rate, where historically readmission rates, even at academic centers much like ours, were in excess of 20 to even as high as 25%. With the new benchmarks based upon implementation of disease management programs, that's now even much more strict and is now at under 18%. So with that financial punitive implication, certainly, most importantly, put it in the context of particular patients, there's a real aim on being clear on which patients we can do more for above and beyond just medicines. And this is just the dashboards we look at, and I wholeheartedly believe in measuring those processes and matrix in terms of recognizing where you stand. And certainly, one admission is a surrogate, if you will, or red flag of potential progression. And this is from Sudaguchi and the Mass General group, and up to over 15,000 patients. Patients coming in and out of the hospital signal that they're not doing well, with a 1-year mortality as high as 40% for those that are in the hospital, just 3 times. So certainly, we use this as a sign to do more. Now, the guidelines certainly discussed discussion earlier with systolic heart failure, and I think that's where we've done a lot of good. And heart failure with preserved ejection fraction, that's the symptoms and signs of heart failure, ejection fraction above 40–50%. The reality is we see both these phenotypes in the hospital, and they're associated with an event rate, as I mentioned earlier, that's high as 1 out of every 3 patients. I think whether it's heart failure with preserved EF or heart failure with reduced EF, the sine qua non, at least from an underlying hemodynamic standpoint, is that the left atrial pressure is elevated and accounts for the breathlessness and with exertion and with lying flat or orthopnea. And certainly the underlying hemodynamics related to perfusion can be a main contributor to fatigue. Secondary pulmonary hypertension is the mediator, if you will, between right-sided heart failure and left-sided heart failure. And we all can appreciate that the number 1 cause for right-sided heart failure is left-sided heart failure. So I think there's a real potential from a concept standpoint, certainly to go at the, again, sine qua non of heart failure from a hemodynamic standpoint and monitor left atrial pressure. From a concept and procedure standpoint, that may be more challenging. I'll give you an update on the St. Jude laptop device in this regard. But perhaps easier is to measure, much like we do routinely with right heart catheterization, is to measure pulmonary pressures and right-sided pressures. The concept is, and we've learned this from actual trial work by Aziel and colleagues, is that for an individual patient, their threshold to decide to go to the hospital can vary. And there's no one standard, what is their left atrial pressure or wedge accounting for that threshold for them to come in. And we think that this tends to start to increase several weeks, if not perhaps for some patients months before. And if we could gauge that uptrending filling pressure, we could perhaps be more proactive with the medicines that were discussed to curb readmissions and make patients feel better. And I think that would be key. Now, as it relates to the physical exam, which is certainly the standard, when you look at data as published, dating back 10 years ago in the European Journal of Heart Failure, the accuracy of detecting elevated left-sided filling pressure in the context of RALs or bronchial breath sounds, or assessing central venous pressure to detect right-sided heart failure as a surrogate of left-sided heart failure, while it's certainly the standard and we all teach it to our medical students and it's key to guide therapy, its accuracy in terms of invasive hemodynamics is not good. The reality, even in the context of, being more aggressive with diuretic therapy in the hospital, as was examined in the dose trial reported earlier today, as well as CRESS, many patients, unfortunately, still at the time of discharge, have either symptoms or signs of fluid excess. And certainly, while in the acute decompensated heart failure state, as we learned earlier today, the goal is to reach euvolemia, and there's no proven medicine that's altering the natural progression. I still think there's a room for being more aggressive to try to minimize, maximize that threshold or difference between that wedge, the time they go home, to the time they'll be admitted the next time. So I think there is this continued gap in that setting. We all certainly, as part of the disease management, follow patient symptomatology, physical exam, and teach our patients to follow their own weight. And when you two look at sensitivity and specificity in weight in terms of assessing decompensation as measured by readmissions, it unfortunately is not there, as published by Lewin and Abraham and colleagues in at least a few reports. So in terms of the modes of monitoring, to be clearer about the underlying hemodynamics that are changing, really there have been examination of pacemaker-like devices, the PA sensors, the CardioMEMS device, I'll go into some detail, and certainly what I think would be the most accurate is direct left atrial pressuring. I'm not going to spend a lot of time on taking advantage of pre-existing AICDs to quantitate impedance, which is a surrogate of thoracic fluid content. The reality is, and I think this is in keeping with the data as put forth on this slide and the references below, is that the positive predictive value is not where we want it. With it being, in some studies, as low as 5%, you can miss 19 out of 20 patients in terms of it being a false positive. So again, its accuracy to guide you is not where we want it to be. And this slide here stems from Zile's work in terms of using a chronicle ICD device to estimate end pulmonary diastolic pressure. And what it defined for the first time was that whether it's systolic heart failure, as highlighted in blue, or diastolic heart failure, these pressures really do start to increase, days, a few weeks to more than several days before that threshold and that hospital event. And when you compare just using body weight to the RV diastolic pressure data from the COMPASS trial, really weight increase didn't change for that particular cohort, whereas the RV diastolic pressure, as illustrated on the left-hand side of the screen, starts to increase. Again, right-sided heart failure as a sign of progressive left-sided heart failure. And while there's no necessarily line in the sand at what defines for an individual what the target is, at least from sub-analysis of the COMPASS trial, when the wedge estimated, if you will, pressure was above 18 millimeters of mercury, these patients were at higher risk in terms of readmission. Now, the left atrial pressure monitoring has received attention over the last several years, and what it does require is interatrial septor puncture. And this multi-center trial, the LAPSTOP study, was done in most centers in collaboration with electrophysiologists or interventional cardiologists specialized in interatrial septal puncture to place this monitoring device across the right atrium into the left atrium. Patients would be put on antiplatelet therapy, and then one would have access to their left atrial pressure via a PAM unit, which looks like your cell phone, and the patients can follow and track their left-sided filling pressure, much like a diabetic patient would in terms of checking their blood glucose, in terms of giving themselves insulin based upon a sliding scale. And so the concept is that we bring the patient into the front of this management and prescribe what we would want ahead of time in terms of what the left atrial pressure would be, typically with escalating diuretics or the use of thiazide-based diuretics. Now, the reality is with this trial, it actually was aborted prematurely because of pericardial effusion. And we were significant contributors to the trial, at least enthusiastic, based upon anecdotal experience with individual patients that had a high burden of dyspnea. But what it tells me in terms of the application and placing this device at the national level, perhaps we're not there yet in terms of safety. So let's focus in on the CardioMEMS system, which has proven to be safe and efficacious. And this pressure sensor is implanted via right heart catheterization. I'll give you the stepwise approach, and it's placed in the left pulmonary artery. It's 10 millimeters, these 2 loops, nitinol, and a piezoelectric sensor that allows for direct pressure, PA pressure monitoring with high-grade accuracy. Patients go home with a pillow and an electronic system that allows them to record their PA pressure, and it's transmitted via the website to where you and/or your mid-level or ancillary support staff can actually pull up their pulmonary pressure readings. The CHAMPION trial, published in Lancet in 2011, really was a landmark trial in this regard. 550 patients with shortness of breath, class 3, 1 hospitalization in the previous 12 months to tease out a patient population that was sicker. Everyone received the PA pressure, but it was not used in terms of access to the information in the control arm. So patients received standard of care versus access to the pressure readings, and I'll define what those goal hemodynamic measurements were. Importantly, primary endpoint was rate of hospitalization with key secondary endpoints as highlighted there. So the goals were to try to maintain this euvolemic status, at least in terms of PA pressure surrogates, with systolics under 35, diastolics under 20, surrogate of wedge, and importantly, a mean pulmonary pressure under 25. So whenever evaluating a study like this, you want to know if the characteristics were similar between the control group versus the treatment group and how sick of a patient population was this. So the majority of patients had a depressed EF, but not an insignificant, roughly a quarter had presumed diastolic heart failure, on appropriate background medical therapy, and multiple comorbidities in keeping what we see clinically. And this is one of the take-home messages in terms of the cumulative number of heart failure hospitalizations as the primary endpoint. There was a 37% risk reduction when using the hemodynamic monitoring data treatment versus control, and this was at greater than 6 months of follow-up. So that was key and important when evaluating any type of a device is safety. In terms of device-related or system-related complications, very low. Pressure sensing failures similarly was very low, and the secondary endpoints as defined there in terms of efficacy look very favorable. And again, more data related to device-related system complication and freedom from device-related complication, which were good. Now, what's happening, for an individual patient and for this cohort was that what one would anticipate. Physicians were making medication changes based upon knowledge of the PA pressure, treatment blue, control in the gray. So the traditional symptoms and/or signs was largely equivalent, but knowing the knowledge of the hemodynamic, that was certainly the aim of the study, led to increased use of more medicines. And when you targeted the PA pressures in terms of achieving what you wanted to, as you see in the treatment in the red, the mean pulmonary pressures for those cohort of patients, again, that's half, decreased significantly compared to control. And intriguing data when you compare it to the standards of care, if you will, the number needed to treat to prevent 1 hospitalization derived from the CHAMPION trial was 4. And so I think that's encouraging results. Now, in heart failure with preserved ejection fraction, much like I presented in the setting of shock, really no data has come forth that's proven to be safe and efficacious. However, in a quarter of these patients that had heart failure with preserved EF, compared to control, heart failure hospitalization was significantly reduced. And there was a more recent publication over the past 18 months capturing that concept. And also, similarly encouraging in those patients with comorbidities where the physical exam, understanding the contributor from the heart in terms of the breathlessness for a COPD patient, having the hemodynamics help significantly in terms of heart failure reduction at 15 months in a treatment group compared to control across these comorbidity domains. And in those Medicare beneficiaries, if you will, 65 years old or older, similarly, based upon this retrospective analysis, significant reductions in heart failure hospitalizations at 30 days, all cause and heart failure related. And one would ask, well, you know, does appropriate guideline medical therapy influence achieving these results? And based again on post hoc analysis of the CHAMPION trial, even in the presence of guideline-directed appropriate medical management, there are still significant reductions in heart failure hospitalizations. So in summary, the CHAMPION clinical trial, the goal is to, in addition to the clinical standards, try to achieve these normal pulmonary pressure readings with the hope of curbing readmissions. Very intriguing, really post-CHAMPION follow-up in terms of open access to those patients that were in the control group, roughly 177 patients. When they crossed over, you can see a significant improvement in their hazard ratio where these patients whom had been treated with standards of care did much better in terms of reduction in hospitalization and how they felt when their physicians had access to their underlying hemodynamics. So with this data, the FDA approved it. There had been some delay in the context of concern about influence from industry in terms of guiding treatment in the treatment group. But it's approved for simply unscrew the cap and this deploys and we take the wire out. So the device sits vertical as seen here in the distal left pulmonary artery and does not move. And this is all done via fluoroscopy. We calibrate and ensure appropriate hemodynamics. And we have this ability to then monitor these pulmonary pressures over time and typically initially review it weekly, red being systolic, blue being mean, and green being diastolic. And this proves to be very highly accurate. Just a few cases to take home the points. This was a patient referred for heart transplant with initial systolic pulmonary pressures in the 50s, with reoccurring admissions for heart failure despite our best attempts and guideline-directed therapy, able to achieve meaningful reductions and kept them out of the hospital. Similarly, someone who was listed status 2, not quite need for status 1B or 1A upgrading in the context of the use of onotropes or balloon pump or even VAD, and really with taking advantage of hemodynamic monitoring, we're able to have a nice reductions in PA pressures, which actually gives us confidence in terms of transplant, higher likelihoods of success in terms of minimizing RV failure on the back end, but really we're able to continue to maintain this patient as status 2. So this has become part of our heart failure disease management protocol, if you will, for select patients that are refractory despite aggressive medical therapy and standards of care. So in summary, heart failure remains a problem, even in the context of improvements in medicines that was nicely highlighted by the previous talks. Secondary pulmonary hypertension is a hemodynamic surrogate of left-sided heart failure. And the CardioMEMS system accurately tracks the pulmonary pressures, and incorporating CardioMEMS can curb heart failure readmissions in selected patients. I appreciate your attention.
Thank you. Excellent. It was excellent.